Is a huge deal. People fly from around the world, around the country, to be seen by him. I have thought myself, I've got a decent smile, but I've been thinking for the last couple of weeks that I've got a crown here that I could use a little touch up from David. He has been an awesome individual to work with. We've been doing this series, Real Talk with David Hornbrook, for a year now, I think, right? I think this is.
I think this is our 11th, right?
Okay, so we're 1 month away from that,
Yep.
but we're coming up on a year, and this was something that got started during COVID. As you guys know, events stopped, and we still needed to get education out there. And with David, not only being a wonderful cosmetic dentist himself and being able to offer a wealth of knowledge, David also has a phenomenal network of individuals that he wanted to help get out in front of the country still and be able to share the messages they had to share. And so this has been an awesome platform. And for those that are repeat visitors, thank you for coming. We're grateful that you've been along with us for the ride. Tell your friends, if you haven't already, to come and keep joining us. This is a series that we will continue to run every third Thursday of every single month. So next month we'll be on again that third week in September. I'll go ahead and pass things over to David with that introduction. Thank you, David, for having me on tonight.
Oh, thanks.
And excited for our guest speaker.
Oh, yeah. Thanks so much. Thanks for hosting this at Dental Intelligence. Stephen, if you could do one thing for those that had missed some of the previous ones, because we've had some really good guests, they can go to YouTube. They can either look up Real Talk with David Hornbrook, or you guys have a channel, right?
Yep. And I'll go ahead and actually throw the YouTube channel into the chat so people can see that.
Okay. So this is live. So if you do have questions, as Stephen mentioned, I kind of monitor that. If I feel it's apropos and I feel Kent is in a spot I can interrupt, I will interrupt him. As Stephen mentioned, if I don't get to you, it was either a really dumb question, which we get those sometimes, or it's something that I think probably should be answered in the end, and we'll get to those at the end as well. Kent will always also give you his email address. If you have any questions about some of the stuff he does, he's going to talk about some of the courses he does, which are amazing. I sent my associate down there. You can email him privately as well if you have any questions about that. But we're going to have fun. This is, I was talking earlier before the attendees got on that Kent and I have known each other 20 plus years, but we only get to see each other once a year. We're both very active members in the Crown Council, and they have their annual meeting every January or first week of February, and it's an amazing event for those people that are not members of Crown Council. I would urge you to look into that. So Kent and I always, we give each other a hug. Maybe not this next year, maybe not. We're not sure where we are with COVID. But we also always chat, and I appreciate what he's doing because he's doing stuff that I'm not doing. I'm not a sleep guy, and I so admire and respect people that have dedicated really their lives and set up goals to be the very best they can be. And he's educated so many dentists, and he's so passionate about what he does. And I just love that, and I appreciate that, Kent. And when I asked Kent to join us, he said, yeah, no problem. I'm available, and we can do it. And, he speaks all over the world. He's a diplomat of the American Board of Dental Sleep Medicine, and he's also the past president of the American Sleep and Breathing Academy. And again, that's not my forte. And it's like, I don't even know what that is, but it sounds important. And I know it is. Sleep and breathing disorders have been probably one of the hottest topics in dentistry right now. And they're not talking about it much in dental school. Yet we see these patients every single day in our practice. And, as a restorative dentist, I see these patients that I used to think were just grinding for whatever reason, and they wore down their dentition. Now we always throw the fact that sleep plays a role, or at least the lack of oxygen when they sleep or don't sleep plays a role in this destruction. And we've incorporated airway, and you'll like this, Kent, because you probably didn't know this, airway a little bit into some of the diagnostics and the treatment of these full mouth rehab patients. Otherwise, you're going to do this beautiful dentistry, and it's going to fail because you didn't address the fact the brain's not getting enough oxygen, and they're moving around all night trying to find that, right?
Yeah.
So he has 2 sleep practices in the Dallas area. He's a general dentist that decided he wanted to focus on airway disorders and sleep, and he's educated all over the world. He's also created, which is very unique, actually a billing academy, and it's called Brady Billing. because a lot of dentists realized that their patients' dental insurance was not covering the sleep aspect of it, and where they were the medical insurance was paying for it. So he's created this billing center where you can actually get medical coverage, makes it easy. And I'm sure you're going to talk a little bit about that, Kent, because I know that when my associate came back from your course, we were frustrated. It's like, wait a minute, how do we get the patient to, insurance to at least help this patient out? And so you've done an amazing thing by helping us out. Before I turn it over to you, Kent, I do want to thank our two sponsors. Obviously, Steve represents Dental Intelligence, and for those that have seen us before, you know how strongly I feel about dental intelligence. If you haven't looked it up, Google it and at least check what they're doing. It basically allows me, and I just have an app on my phone. I check every single day. I wasn't in the office today. Check and see what my associate's doing and what I'm doing when I go back on Tuesday. It allows you to really evaluate all the metrics in your office that you need to know on a daily basis. You have to evaluate patients, insurance, treatment plans. And, I've said it before, I had PracticeWorks for 35 years as my dental software. And unfortunately, Dental Intelligence does not work with PracticeWorks. So this last year during COVID, we changed over to Dentrix with the primary goal. And it was a major issue, as you know, for those that have transferred practice software for 30 plus years. We transferred over to Dentrix with the primary goal to use Dental Intelligence, and it was absolutely worth it. Dental Intelligence, absolutely worth it. So I appreciate them sponsoring. They're actually the host of this. And second is Utah Valley Dental Lab, which I'm the clinical director of education. They do all my dentistry, and they work with some of the, I think, the leading practices in the country. And so if you're looking for a dental lab, whether it be cosmetic or restorative, it's a full service lab. I want to thank Utah Valley for co-sponsoring this as well. So without further ado, Kent, welcome. You're in Dallas, and you're also, and one thing that you sent me that I did not know is that you're a suspense writer. Is that fiction or non?
That's fiction. Yeah.
Fiction.
Yeah.
I did not. In your spare time, when you're not sleeping.
Well, yeah. Yeah. Well, hey, first I want to say though, Steve probably doesn't even know this, but we've used Dental Intel for years, and I'm a huge fan of it. And we've got in our dental office, we've got 3 separate huddles because we stagger everything. And so Dental Intel is used on the big screen every morning in every single huddle. And I couldn't say enough good things about Dental Intel. So we still say Dental Intel. Is that not correct? You're supposed to say
I do too,
word intelligence.
Yeah, I say Dental Intel. I was trying to give them the benefit of the doubt in case they needed to Google that, but Dental Intel, DI, yeah. Right?
Anyway, yeah, so I've, someone, I think in fact it was Steve Anderson, David, that said, he told me in some lecture he did, he said, only 2% of people who ever say they're going to write a book actually write a book. And I said, challenge accepted. So COVID came along, and I had already started one, and that allowed me to completely finish a book, and I got that published. And now I'm about 90% through with my next mystery, which is actually a sleep mystery, and really looking forward to that one being finished. So wow. It's a passion of mine now, in addition to sleep.
Are we going to see it on the silver screen someday?
Yeah, probably.
I know. So the first one is called what?
Yeah, The Unfortunate Gift.
Okay.
The Unfortunate Gift. Yeah, you can get it on Amazon.
Okay.
All right, but that's not what we're here to talk about today. We're talking about sleep, and I know a lot of people are curious about this. If you haven't been to a seminar, I know we probably have a mixture tonight of all the I don't know how many are on, but I'm sure we've got some that have had some sleep education, and many that have not. That some people have dipped their toes into it. It's not an easy field to get into. It's just not. There's not a magic wand. I think some people are kind of forced into it. They become disabled, and that's, I've got one female who has narcolepsy. She decided she couldn't practice dentistry anymore, so that forced her into sleep. And there's a lot of stories like that, but it is a field that you can practice totally disabled. You can do this with very little talent, which is why I got into it, because I like things that are easy, although it took a lot of work to get to where I am. So we all sleep. We spend a third of our lives sleeping, and yet how many of us really pay attention to it and its effect on what happens to us during the day? You know, anything that you do during the day affects how you sleep, and anything that happens during sleep affects what happens during the day. It's heavily intertwined. So if you don't feel like you know enough about it, you really should get involved and at least learn something about what goes on during sleep, because it's so important for not only you, but your patients and your team. If your team isn't getting enough sleep, they're not going to produce effectively, and they won't be the best team that you can have. Let me start out with saying that I have absolutely no disclosures. I've been asked many times to buy into sleep companies and different things, and I've refused every single time because I don't want to ever feel like that I'm beholden to them to say something that I would rather not say. So why do we even care in dentistry about sleep? We didn't learn at all. And I asked this in a lot of my seminars. I asked people, dentists, how much sleep education they had in dental school. And sometimes you'll have somebody that'll say, well, I had a couple of hours. And usually that's when they're in a city where there's a sleep dentist, and they go in and they'll talk for an hour or two at one point during their sleep dental education. But in general, we haven't learned anything about sleep by the time we get out of dental school. But there are many reasons we should be involved in it. And this is why the ADA, I want to say it was about a year ago, I can't remember exactly when this came out, but the ADA came out with a policy, and they said, listen, guys, everybody that's a dentist should be screening for sleep disorders. Everybody. This should happen with every patient that you have. So depending on how much you want to do that is totally up to you, but it's not something that the ADA feels like you should be ignoring, because it does impact, as David said, it impacts your dentistry. It impacts the overall health of your patient. I think we're trying to get away from just being architects of the teeth. We're trying to be more holistic in our treatment of our dental patients, and this is all part of it. I'm not going to read all the stuff that they said, but basically they said you need to be involved in screening, because we see patients every 6 months in the dental office, at least. Physicians don't. In fact, I talk to OB-GYNs. OB-GYNs, many of you will realize that either you or your spouse, your girlfriend, your mother, that's the only doctor they see. They don't even have a PCP because they've been seeing the OB-GYN, and that's become their physician. The OB-GYNs aren't screening for sleep either. And it's really discouraging to me that they are not being screened, they're not being diagnosed. 30 years ago, Dr. John Young did a study and said that 85% of our patients in the United States have undiagnosed sleep apnea. They've got it, it's just not diagnosed. He did another study 5 years ago. 85% of the population is undiagnosed. We've gone nowhere in the last 20 or 30 years, which is sad. I really wish we did a better job of screening and getting our patients diagnosed. And that's been one of my missions for all the years I've been teaching this, is to try to get dentists to do this. But it's entropy. You learn a little bit about sleep, you go back into your practice, and you go right back into doing your crown and bridge and veneers and root canals and orthodontics and everything else, and you don't even think about asking questions about sleep. And I get that. I understand it. It's just, it makes sense. But that's why I encourage anybody that would like to do a better job of this to at least put a question in their health history form. Something in there that will cause you to remember that, hey, yeah, I need to be screening about sleep. You know, at least ask, do they snore? Have they been told they snore? Have they ever been given a CPAP machine? How often do they wear it? I mean, just some simple questions like that, because they're not going to talk to you as a dentist about sleep because they have.
Can I interrupt you for a minute here?
Of course.
Okay, so the way you shared your screen, it's in like presenter mode. So the
Uh-oh,
slide.
I didn't mean to do that.
Yeah,
how do I get it out of presenter?
Yeah, what's that?
How do I get it out of presenter mode? Because I didn't do that on purpose.
That's a good question.
Click on display settings. There's a little like down arrow, and it should say up on the top there, and it should say switch to, so over to the left.
Right up there.
It says display settings.
Oh, display settings.
Yeah, just because you have so much written there and so much good stuff that we can't.
And then click on swap.
You can't read it.
Swap presenter view. Click on that top one. There we go.
There we go. Good. Perfect.
All right. Now
okay, you're going to have to start over now. Sorry.
Now can I advance slides? I think I see how I can do that. Okay, I think we're good. Yeah, thanks for letting me know, because I didn't know if I was the only one seeing that or not. But
no, it's actually Kimberly, one of our attendees, said, "Hey, you know what? There's a lot of good stuff to read. We can't read it." So
okay,
we'll give her the credit, not me.
Thanks, Kimberly. I appreciate the heads up on that. All right. So one thing that if you aren't involved in sleep, you're probably not even aware of this. But just 2 months ago, 4 million CPAP machines were recalled from Respironics. They discovered that some of the filter, some of it was breaking loose, the padding was breaking loose, and they were ingesting it into the lungs, and it was causing lung cancer. So all of a sudden, in 2 months, you've got 4 million CPAPs that were made from 2009 until April of this year that have been recalled. And I've been going on Facebook groups about this, and these patients are desperate. They don't know what to do. The Respironics is not communicating with their constituents. They have no idea, unless they get on social media, this has even happened. So I talk to patients, they'll come in and they'll say, yeah, my mom's been on a CPAP, but I don't want a CPAP. I want to wear an oral appliance. And I'll say, does your mom know about the recall? Well, what do you mean? Well, does your mom have a Respironics? Respironics and ResMed make up 97% of the marketplace of these CPAP machines. Does she have a Respironics? Let me check with her. Let me contact her. Oh yeah, she has a Respironics. She needs to be told that they have been recalled. Respironics is going through all kinds of class action lawsuits. There's no telling if they're going to come through this alive. But this is a good time for dentists to be doing this, because there's a lot more need right now because of the number of patients out there that are desperate. In fact, some are totally losing, well, they don't want to wear a CPAP anymore, period. Even if the CPAP company says we fixed the problem, they don't trust them anymore, because it's artificially taking air in the room, it's bringing it through the machine, and it's blowing through their nose into their lungs. And this will never change. That's what CPAP machines do. So if they've lost faith in the ability to use one of these machines, there is untold need right now for you to be talking to your patients. If nothing else, if you don't get anything else out of this talk, start asking your patients if they have a CPAP machine. If they do, if it's Respironics, it's probably been recalled and they have not been told. They'll be so appreciative you told them that. All right, so let's get into just the basics of sleep. Why do we even sleep? If you ask 20 different sleep doctors, why do we sleep? You'll get different questions. There's lots of good reasons we sleep. Good things happen when we sleep. Bad things happen when we don't sleep. You know that team member that comes in and hasn't had good sleep the night before, well, they're not in the best mood, and you can kind of tell. Or that team member that comes in and says, don't talk to me till I've had my cup of coffee. Sleep is important. It's important for concentration, and in the dental chair, and you're trimming those margins, and you've got to be able to concentrate. withstanding pain, having a better immune system, avoiding COVID. If you get better sleep, you can better avoid COVID. So many reasons to get good sleep. Many of us don't get enough. To my patients, we always talk about not only having quantity, but quality sleep. We help them with quality, but many times they still don't get enough quantity. They just don't have enough time. They're burning the candles at both ends. Sleep is important. It's important for growth hormones. In our deep sleep is when we get growth hormone released. In kids need growth hormone to grow. Adults, we don't need growth hormone to grow. We need growth hormone to restore ourselves after a hard day. You have hard days every once in a while, right? Bending over patients all day long. You want to go home and have a little tequila, a little bourbon, something like that. Problem is, if you don't get enough deep sleep, you can't recover appropriately and be ready for the next day because you didn't have enough growth hormone released. There's also something called satiation hormones. Leptin is something that is also released and circulated in deep sleep. Deep sleep allows us to circulate leptin, which tells us that we're full. So if you don't get enough deep sleep, you don't realize you're full as quickly, you're more likely to make bad food choices and to keep eating. Deep sleep is when all this stuff happens, and with obstructive sleep apnea, that's the first thing that we lose is deep sleep. I had a patient today, he was 24 years old. He already has very, very severe sleep apnea. You have to stop breathing 30 times an hour to have severe sleep apnea. His number was 97. 97 times an hour, he stops breathing for at least 10 seconds. He had this little sliver of deep sleep. You should have 15, 20% deep sleep. He had 3%. So that's just very common. You need deep sleep to recover, to make right food choices, all of this. If you don't get enough of it, you're in trouble. There's also something called the glymphatic system that was discovered a few years ago. And this is fascinating. You all know about the lymph system, or maybe you don't, but the lymph system helps us get rid of waste. Basically, that's what it's doing. But we never knew how the brain got rid of waste. Not until just a few years ago, they found the glymphatic system. And what happens is in the cerebral walls, cerebral spinal fluid runs up the arterial walls. It flushes through the brain tissues and it exits out the venous walls. If you don't get deep sleep, the brain tissue, the astrocytes in the brain stay swollen and the fluid can't wash through effectively and cleanse the brain tissues. So they've discovered that without deep sleep, you don't get this cleansing. This leads to early Alzheimer's and dementia. So one of the primary reasons for developing early Alzheimer's or dementia is not getting good deep sleep throughout your life. Sleep gates. Now, this is something that you probably are familiar with. The most likely time for car crashes is between 11 at night and 5 in the morning, because that's when you should be sleeping. The next most common time for a wreck is about 2 o'clock in the afternoon. Though this is a natural sleep gate, your respiration slows down, your heart rate slows, your blood pressure drops a little bit, your body is preparing itself to take a nap. Now, if you're in Mexico, like Dr. Hornbrook, they have siestas, right? They listen to their bodies. Spain has siestas. A lot of countries have siestas, but not in the US. We work right through it because we have to be productive, right? Now, Google and a lot of companies have created these nap pods. They've realized that their people can be more productive if they're allowed to take afternoon naps. So I've often thought about putting a nap pod in my office, but I'm an American, so I'm not going to let my team take naps either. Sleep debt. Yeah, that's a problem in most of the US. You need about at least 7 hours. I mean, 7 hours is what we consider the minimum, unless you're what we call a short sleeper. The average female needs a little bit more, about 7 hours and 46 minutes. The average male needs about 7 hours and 34 minutes. Of course, there's variety. Everyone's different on those scales. But if you're not getting your 7.5 hours, it can be bad for your health. So the right amount, 7 hours. They did a study of over 1 million men and women, a pretty big age range. Your best survival rate was getting 7 hours. If you got less than 6 or more than 8, your mortality increased. So you don't want to die early. If you don't want to die early, let's get the not too little. As you know, teenagers don't get enough. They go through what we call a sleep phase delay. It's something that happens in puberty. They go through puberty. They can't go to sleep as early as they used to. Technology doesn't help. Those of you with teenagers, some of you probably were teenagers. You know what it's like being up late at night. You just don't want to go to sleep. You stay up late. Then you have to get up early to go to school. And you don't do well in school when that happens. So what happens when you get a lack of sleep? This was a study, the British study they did over 17 years. You drop 2 hours of sleep. This is just quantity. We're not talking about quality yet. Quantity, you drop from 7 hours to 5 hours, you double your risk of cardiovascular death. So it's not just quality, it's quantity. You need to get enough sleep for your heart. 7 hours, they discovered that's what's optimal for health. Fitbit. David, what would you say is the national bedtime? What would you guess if Fitbit looked at millions of people, they knew when the average person goes to sleep, what would you guess that time is?
I'd probably say 9:30, 9 to 9:30.
11:40.
Are you talking about me or the average?
The average. So you go to bed at 9:30, and that's not the averge. 11:40.
No, I don't go to bed at 9:30. All of a sudden, 11:40 looked kind of apropos to me.
That's okay. Yeah. So I would assume a lot of you out there, you're going to bed closer to midnight. What about the national wake time? What do you think that is?
I don't even want to guess. I was so off the first time.
It's 7:08. Yeah, I think most in dentistry get up earlier than that, but I don't know. Now that's about
7 hours.
7 hours and 22 minutes. So, no, yeah, 28 minutes, 7 hours and 28 minutes they're getting asleep. So that's about 7.5 hours. So that's good. This is something that a lot of people are concerned about. Obesity, diabetes, insulin resistance. Just getting 30 minutes less sleep each year will increase your obesity by 17%. So it also makes you more likely to develop diabetes, just 30 minutes difference. So if it's not on your to-do list to get 7.5 hours of sleep every night, you all need to do it. You need to get your team doing it. You need to get your patients doing it. And anything that interferes with your sleep harms what we call sleep efficiency. Now, when we talk about sleep efficiency, from the time you go to sleep till the time you wake up, your sleep efficiency should be about 90%, at least 90%. If it's not, there's a problem. Now, many things can lead to sleep efficiency. We talk about sleep hygiene with our patients. If you're having too much caffeine during the day, if you have light in your room, if you have noise, if you have a bed partner that moves a lot or that snores, if you have animals in your bedroom, if you have too much alcohol before you go to sleep, all of these things can harm sleep efficiency. One of the sleep studies that we use, my favorite sleep monitor is called the WatchPat, and it measures sleep efficiency. So we've been getting sleep efficiency numbers on our patients for many, many years. I've got a little side research project that I'm doing on my own, where I'm asking every patient I see, what kind of a mattress they sleep on, soft, medium, or hard. I look at their sleep efficiency. I ask them what temperature they put their thermostat on when they go to sleep. I look at their AHI number, which is their severity of sleep apnea. And I look at all of these things, and I look at the number of times they turn over in bed, which can impact sleep efficiency. Some patients, they lay down on their back. They never turn over all night long. They sleep in one position all night long. But some people change positions as many as 50 or 60 times. That's terrible for sleep efficiency. It can be caused by a lot of things, but it is one thing that we look at when we have our patients that come in and say, listen, I don't sleep well, doc. What can you do for me? I'm terrible. I wake up, I'm fatigued. Well, first thing we do is give them a sleep study. Also, if you didn't know this, making your bed is important. They've done a study that shows you're more likely to get good sleep if you make your bed. So if you learn nothing else from this seminar, make your bed in the morning, you'll probably get better sleep at night. Your chronotype, all right? So we know that evidently David's gonna be what we call a night owl because he stays up later. I think he's an admitted night owl. That's if you stay up late. If you're a morning lark, you like to get up early. If you're a hummingbird, you're right there in the middle. I think it's much easier to be, the percentage, hummingbirds are about 60%, night owls are about 30%, and then these morning larks are only about 10% of the population. You can learn to be a morning lark. It's better to get up early, go to sleep early, wake up early. Ben Franklin had it right. So I'm just going to go through this. We don't need to belabor any of this because I know we only have a certain amount of time. Coronary artery, the heart is the first organ, the most important organ that is impacted by not only a lack of sleep, by quality of sleep. When I talk to my patients about their heart, and that again, we see hypertension as one of the first things that crop up in a patient with sleep apnea, but also in a number of hours of sleep that they get. I tell them, you know what, if you're not breathing well, you're not getting enough oxygen, your heart has to pump faster because your heart is supplying the blood that then carries oxygen to your organs. If you're not breathing in enough oxygen, the heart has to work overtime. It should be resting during sleep. It doesn't get a chance to do that when you're not breathing. So you're much more likely to develop coronary artery disease, have a stroke, cardiovascular diseases of all kinds, of course, hypertension. This is what it looks like at midnight now. If you take a picture from space, this is what the United States used to look like. What do you think it looked like in 1600? You think it looked like this? No. After the Industrial Revolution came along, we started developing an issue going to sleep. There is an interesting study called Night in Times Past by Urkic. It's a fascinating book on how we used to sleep. We all used to have 2 sleeps. We would go to sleep when it got dark. We would wake up after 4 hours. We would do some things around the house. We would clean. We would write on our diary. We would have fun with the wife. Then we would go back to sleep for 4 more hours and get up. It was never written about because it was normal. Well, that eventually got squished. Now we only have 1 sleep, but some people still wake up in the middle of the night and they don't know why. There's a whole bunch of people that do this. They have this own subgroup. They're contacting each other at 2 or 3 o'clock in the morning because they can't go back to sleep. All right, now the types and stages of sleep, there's REM and non-REM. You've all heard of REM sleep, that's rapid eye movement. You either are in rapid eye movement or you're in non-rapid eye movement. These stages last about 90 to 110 minutes. You go through 4 or 5 of them every night. And these things are measured on a polysomnogram. Now, when I say the word polysomnogram, that's a sleep study in a sleep lab. An HST is a home sleep test. And that's what 95% of studies are like these days anyway, because the technology is there. They can be done in the home. Those are home sleep studies, or HSTs. If Few differences in REM and non-REM. REM we call paradoxical because our mind is very active. That's when we're formulating thoughts. And if we could remember every dream we have, we could be very creative. And those that can remember their dreams are the more creative branch of people. You become creative if you have good dreams that are consolidated and that they're long enough and they get interrupted by sleep breathing disorders. You don't remember your dreams as well. So when we get somebody breathing again and having good sleep, one of the most common things we hear is, I'm dreaming again. It's been forever since they remember having dreams. But when you're dreaming, your body is paralyzed so that you don't act out your dreams. So active brain, paralyzed body, that's why it's called paradoxical. Because you want to act them out, but you can't because you're paralyzed. 50% of infant sleep is this REM type sleep. It's because REM sleep is important for consolidating new information and putting it into the right part of your brain. Those of us that have been around a while, we remember defragging our computers. Do you remember that, David? Used to defrag your computer? Yeah. Defragging, people don't think about that much, but you could watch it happen. It would all kind of coagulate over into one little section of your screen, and you knew that's when it was defragged, because it took all these bits and pieces of information and it would put it in the right spot. That's what happens in REM sleep. When we're learning things during the day, if we learn a lot, we need more REM sleep to put it in the right position to bring it up in memory later on. But if we don't get good REM sleep, we can't remember things as well because we couldn't defrag our brain and put things in the right spot. Infants have so much REM sleep because they have so much to learn. Everything they learn is new to them. Us old codgers, we don't learn very much. Yeah, we may learn a few things during the day, but we don't need as much REM sleep because we don't have as much information to shift over and defrag our brains. N1 sleep is that stage of sleep where if somebody says your name, you wake up. So it's a very lightest level, about 5% of your sleep. N2 is a little bit deeper. It's where you might sleepwalk. Those of you that do sleepwalk, it's about 10% of the population has slept walk or does sleepwalk. You do this during stage 2 sleep, not during REM, not during deep sleep. You don't need to know too much about this. These things they will show up on sleep studies when you do them. There's also something called the myoclonic jerk, and you probably know what this is. It's when you're just sort of drifting off and you jerk up like that. It's also called a sleep start. The science thinks that it's your ability to transition in from the wake to the sleep state, because it's kind of a tenuous transition. Your systems that are operating when you're awake, they kind of go to sleep when you go to sleep, and new systems have to turn on. That's why sometimes we can't maintain an open airway, because we're going to sleep. Our intuition that says, keep your airway open. None of you right now are probably snoring as you're watching this. I don't know if you've gone to sleep already, okay, maybe you're snoring. But if you haven't gone to sleep, then you're not snoring and you don't think about it. You're not sitting there going, don't snore, don't snore, don't snore. No, you're not doing that because you inherently know how to keep awake and to hold your airway open. You don't do that when you go to sleep. So your body says, wait a minute, we've got to reboot. We've got to start this thing over again because we weren't quite ready to turn on those overnight systems. That's what we think a myoclonic jerk is. Now, N3 sleep, that's your deep sleep that I've referenced already a few times. It's for growth and rejuvenation, to recover effectively, to establish the right hormone levels, etc. Now let's go into the different types of sleep disorders. You've got parasomnias. I talked about sleepwalking. Sleep talking is a parasomnia. I have one patient that built a set of shelves during sleep. Patients are using this as a defense mechanism now in court because they'll get up. There's a story about one guy that got up, drove 3 miles, went into his in-laws' bedroom and killed both in-laws and got off because he said, I was sleepwalking. So these are parasomnias. Dyssomnias it's the other type, and it's the thing that we deal with. Sleep disordered breathing is a dysomnia. Insomnia is a dysomnia. Many of you have insomnia. It's the only sleep disorder that's more frequent, more common than sleep disordered breathing. And there's a lot of crossover too. It's thought that about 90% of insomnia episodes during the night are related to a breathing disorder. So if you've got a patient that has insomnia, that's why we give, if a patient comes in and that's their only complaint, I've got insomnia, I don't snore, you need to get a sleep study. We need to see if this is in fact a breathing disorder that's bringing this on. So you should be talking to your patients again about any kind of sleep problems. It's not hard to just lean over and say, hey, how you sleeping? Just a simple question like that. It'll open up a can of worms sometimes. And that'll tell you, you know what? I need to get you looked at. You know, we check your blood pressure every time you come in. We're checking your gums every time you come in. We're checking all these things, but how often have you checked your sleep? It's important to check it. So why don't we just get you a sleep test, just to, hopefully you're fine, you don't have any problems at all, but at least checking the health of your sleep every once in a while is a good thing. That's not a hard conversation to have. And I wish more dentists would do it. Hopefully those of you who are not treating sleep and don't want to treat it, at least you can ask them how they're sleeping and tell them how important it is to get that checked periodically. Different parasomnias, night terrors, and like I said, sleepwalking, sleep talking, hallucinations that people have as they're waking up or just going to sleep. That's what those are. Some people have what we call sleep paralysis, where you'll actually wake up in REM sleep. You're paralyzed, as I said, but you can't move. And I know that there are some people that are listening to this that have had this sleep paralysis. It's not a lot of fun. It's scary, but it's more common in people who nap and people who sleep on their back. So if you are one that has these sleep paralysis episodes, if you haven't already been told, don't sleep on your back and don't take any more naps. That'll help you. Other parasomnias, bruxism. We know all about that, right? That's a parasomnic event. Bedwetting. REM behavior disorder is when you are in REM sleep, but you are not paralyzed and you actually do some things you shouldn't be doing. And then sleep-related eating. You wake up with a turkey leg in your bed. Go, what the heck? Where did this turkey leg come from? Right? That's sleep-related eating. I mean, people wake up with candy wrappers in their bed. And they gain so much weight. People have to put locks on all of their kitchen doors, and their bed partner has to hide the keys every night, hide it somewhere different. I mean, it's terrible, the things that people have to go through when they have these. Sleep sex, we won't get into. It's, yeah, anyway, don't have time to discuss that. Sleep texting, anything you do during the day, you can do during sleep. You can walk, you can eat, you can talk, you can text in sleep. Obviously, this is a fairly recent sleep disorder. Sleep texting shouldn't happen, but it does. If you ever get a strange, garbled text from somebody, you might ask them, hey, when did you send this? You know, if your ex sends you a text and you can't read it, yeah, that's probably what happened. So dysomnias, like I said, are things like insomnia. It's anything that prevents you from getting asleep or staying asleep. It's called a dysomnia. Different dysomnias are narcolepsy, which is not a fun thing to have. You're on meds the rest of your life if you have this. Cataplexy is when you can't be around any emotion. If you laugh, if you cry, if you're sorrowful, whatever that emotion is, you collapse because you lose all muscle control. Also something you don't want, cataplexy. Other hypersomnias, people that sleep 14 hours a day. A lot of people sleep with periodic limb movement disorder people. So if your bed partner moves around a lot and kicks you, and their arm comes over and hits you, and they don't mean to. This is PLMD. It's very common in our sleep disordered breathing patients. It's a side effect that we always want to clear up the sleep breathing disorder first and hope that these limb movements get better. Most of the time they do. If they don't, then the patient has to go on medications for it. Restless leg syndrome is different. This is when you're trying to get to sleep and you can't because your legs are twitching. They're like two eels fighting each other. You have to get up, stand up, walk around, go lay back down. They keep itching again, and it's just miserable. That's restless leg syndrome. If you have that, there's a really good chance you have periodic limb movement in sleep, and you may not even know it, especially if you don't have a bed partner. And that could lead to fatigue, and you don't know why you're fatigued because you don't have a bed partner. You could even use a SnoreLab app, which is my favorite app for snoring, called SnoreLab. It's free. You could use that app and you could say, well, I'm not snoring, but I'm still tired and fatigued. It could be limb movements causing your sleepiness. Circadian rhythm disorders, if you have to have alcohol to go to sleep, that's not a good thing. I understand some people do. I'm not saying don't drink alcohol. You just got to know it can certainly impact your sleep negatively. And then, of course, sleep-related breathing disorders. This is what we can deal with as dentists. This is a dyssomnia. And speaking of alcohol, this is how it impacts your ability to sleep. Yes, you can get to sleep quicker if you drink alcohol. I get that. But the more you drink before bedtime, the longer it takes to get into deep sleep because you're metabolizing that alcohol all night long. If you drink one drink, it takes about 2 hours to metabolize it. You're in your sympathetic nervous system. You can't get into parasympathetics. So 2 hours for one drink, about 4.5 hours for two drinks, about 6 hours for three. And if you've had 4 drinks and then you go to bed, you're going to be metabolizing all night long. You don't get the deep sleep you think you got because it's been sympathetics all night long. So I usually tell my patients, listen, you can have all the alcohol you want to drink for breakfast, just don't do it right before you go to bed because that's going to impact your sleep. This is what it looks like on one of the WatchPat studies. If you haven't ever seen a sleep study, this is what one would look like. Again, this is my favorite. No, the company doesn't pay me. As I said, I have no disclosures. They don't pay me anything, but this is my favorite monitor because it's so easy to read. It's easy to discuss with patients. I can see how many times they stop breathing. I can see like right here, this is how low their oxygen gets during the night. It gets down to 74. Now, those of you that do sedation dentistry, what happens when the oxygen that you have them hooked up to an O2 monitor, if it drops below 90%, what happens? Yeah, they'll start going off. You get a warning. This is dangerous. And you reposition the mandible and you try to get them to breathe better and then the oxygen goes back up. To think that somebody could go down to 74%. In fact, if you hold your breath right now, you could not get it below 90%. You couldn't do it. I don't care how long you stop breathing, you can't do it. Just try putting a pulse oximeter on you if you own one and see how low you can get your oxygen. You can't do it. So to see in a sleep study that these patients get this deprived of oxygen, this patient, for example, right here, 19.7% of the night, he was under that 90% threshold. We want everybody to stay above 90%. Every time you see a blue vertical line, that's when somebody stopped breathing for 10 seconds. So this number right here, this 44.2, that's called the AHI. That's how many times they stop breathing per hour. It's an index. 44 times every hour, they stop breathing for at least 10 seconds. So that's how we measure the degree of sleep apnea for somebody. This patient, because that number is higher than 30, he has severe sleep apnea. But you see these black wavy lines down here. This is the oximetry line. This is what we don't want to happen. This thin line near the top is your 90% line. Every time the oxygen drops below that, it's dropping below 90%. So alcohol during the first part of the night, when the body was metabolizing it, the oxygen hovered under 90% most of the night. It eventually wore off, and then he does pretty good the rest of the night. His oxygen is staying above that 90% threshold. So alcohol can have an impact on sleep apnea. And those of you who have spouses, bed partners, girlfriends, boyfriends who tell you that you snore more when you drink alcohol, yeah, that's pretty common. It makes sense. And this is the reason, because you're less capable of holding your airway open. Your breathing muscles are more flaccid. Cell phones in the bedroom. I would bet if I surveyed everybody that's listening, how many of you have a cell phone in the bedroom when you go to sleep? I would bet 99% of people will say, yep, I do. In fact, I use it for my alarm clock. Problem is, it can create problems with sleep. It can delay your ability to get into deep sleep. It can cause headaches because it's continually talking to the towers all night long. So I usually suggest there have been 2 different university studies that have pointed to this and said it's important to have your phone further away, at least 8 feet from you if you can. If you need to use it for an alarm clock, put it on the other side of the room. If you don't need to use it for an alarm clock, put it in your kitchen, put it somewhere in another room, leave it charging somewhere else. Because what happens, even if you put it on vibrate and you're in that stage 1 sleep, that stage of sleep where if I say your name, you're going to wake up. What happens when you hear that vibrate? What do you do? Do you just keep sleeping? No. You go over and pick your phone up and say, okay, who just texted me? So hopefully a lot of you have figured this out. You aren't doing it, but if you still have your cell phone by your bed, it's not the best for good consolidated sleep. We've already gone over PLMD. I don't think I need to talk more about that, and restless legs. So let's kind of skip through that, get to what we can have an impact on more than anything, and that's snoring. There are different levels of sleep disordered breathing. Snoring is just the first stage. If somebody is a primary snorer, that's all they do, then they don't have sleep apnea. But eventually they develop upper airway resistance syndrome, where they are then getting sleepy as a result of their snoring. And then it develops into obstructive sleep apnea. Now, this happens with weight gain and with age. Those are the 2 things that impact it, in addition to medications and alcohol, of course, that can make it worse. But primarily we think about age and weight making this worse. Problem is, if you gain weight, once you have sleep apnea, it's harder to lose weight. So it's better just to avoid that whole thing to begin with and get your apnea under control. Treat it when it's just plain snoring, and hopefully you can avoid patients getting into these more severe sleep disordered conditions. Central sleep apnea, we see this in the older population, those patients that the brain doesn't send a signal and you just don't even try to breathe. Obstructive is when you're trying to breathe. Central is when you don't even make the effort. And we see that with brainstem injuries and some of the older population, COPD. Mixed apnea is when you have both. You don't want both, but obviously you don't want any of this stuff. Mixed apnea is when you do have both. Complex, this is pretty common. Patients that put a CPAP on, and those of you that aren't familiar with CPAP, it's a reverse vacuum cleaner. In fact, that's how they discovered it. Colin Sullivan in Australia reversed a vacuum cleaner and said, you know what? I think I can blow air up people's noses and cause them to breathe better. And the CPAP came from that. But the problem is when you put one of those machines on people, sometimes the brain says, I've got a machine breathing for me. I think I'm just not even going to try to breathe anymore on my own. That's complex apnea, when you can't adapt well enough to that machine and you develop central sleep apnea from not being able to turn that function on. Now, cataphrenia is sleep groaning, pretty uncommon, but if you sleep with somebody that actually groans when they're asleep, it's usually when they're exhaling, and it's some weird noises. If you sleep with somebody like that, that's also a breathing disorder, but it's on exhale and it's a completely different kind of a sound. I know I'm kind of rattling on here, David. Are there any questions that I need to answer?
Yeah, there are some questions. There's some questions I think we should address now.
Okay.
Yeah, if people are interested in this whole phone thing, right? So, as you say, who keeps their phone, on at night? Freaking I do, right? I mean, that's my alarm clock, right? Who knows? I might get an important text in the middle of the night, right? So if you leave it on do not disturb, or if you put it in airplane mode, I mean, again, if I use it as the alarm clock, I don't need people texting her. Is it still communicating? Would you still say, nah, get it out of the bedroom, use your alarm clock like we used to use?
Now, if it's on airplane mode, as far as I know, I'm not a phone expert, but I think that means it's not communicating anymore. I mean, that's why they tell you in airplanes to put it on airplane mode, right? Because they don't want it communicating with the tower. It messes up their signal. So I have to assume it's not communicating anymore.
Okay, good. Because I think maybe that's what I should be doing. I'm always thinking I'm going to miss an important text at like 3 a.m., right? Since I'm up. And as we get later into this, I'm going to describe me, because I'm like Steve Anderson, right? Never tired, never sleeps, and thinks like everything's okay, right?
Right, yeah.
So also someone did ask, they must have come up a little later. What was the name of the CPAP machine that was recalled?
Oh, Respironics. ResMed. If you have a ResMed machine, that's good. That didn't get recalled.
Okay.
Respironics, that's the problem.
Okay. Yeah. Okay. And you may cover this, and you and I have had this conversation. I don't know if you remember it several years ago, the whole Ambien deal, right? Because I'm a night owl, and if I go speak in Boston, right, so I said 11:30. I go to bed at 1, and I wake up at 5. And so if I go speak in Boston, right, all of a sudden my 1 o'clock is their 3 o'clock, right, or 4 o'clock, but I have to wake up at their 6 o'clock.
Right.
So the only way when I travel and to get a good night's sleep is to take an Ambien. And, I may take two a week, right? Just because that's the only time I feel like I go to REM sleep. Although I do get up in the middle of the night and I go to the refrigerator, I find, protein bar crumbs on the floor. It's like, what rat was in the kitchen last night? But yeah, I realized it was me, right? So are you going to talk about Ambien and melatonin, Lunesta? Are you going to talk about that at all?
No, let's just do it right now.
Okay.
I can divert, this is for your group here. This is for any, I want to answer any questions. That's more important to answer people's questions than for me to rattle on about stuff that you guys don't care about. So,
care about it.
Well,
there are some other people that put that just now in the chat, because I would say I'm a user of Ambien, just as the only way I can get to sleep when I absolutely need to get to sleep.
And there's really, if anything that you do periodically is fine. There's not, as long as you don't have strange side effects, because you can do weird things when you take Ambien. And as long as it doesn't.
I do have to turn off my phone. Because I do tend to text in the middle of the night.
Okay. So as long as you're not, fatigued the next day, if you're not lethargic, if it doesn't impact your day the next day, and you don't have weird side effects, then yes, taking it periodically. The FDA has not cleared Ambien for long-term use. The only thing the FDA has cleared for long-term use is melatonin and Lunesta. Lunesta is safe over a long period of time, and so is melatonin. But I know people that have been taking Ambien every night for 20 years, every night. I get all kinds of stories.
So let's talk about this, because there's been several people that have now brought this up in the chats, and primarily I'm interested, and since it's my show, I get to ask.
Sure, yeah.
I'm just kidding. So as you talked about the different levels of sleep, right? Where does Ambien or Lunesta or melatonin, because I know my physician, who's a naturopath, wants me to take melatonin. She goes, the side effect is you're going to have crazy dreams, right? And I do have crazy dreams. But so where in that sleep cycle, or the type of sleep, as I take Ambien, I feel like I go into a deep sleep, because I'm the guy, Kent, it's like Steve Anderson, for those that know Steve. He's an energetic guy. He's got a million things going all the time, but he's never tired. And that's kind of how I am. People that say they go to Vegas for a weekend, stay up all night, they take a week to recover. I can stay up all night for a week and not have recovered, right? But at the same time, and I'm the guy that's watching my alarm clock. I go to bed at midnight and I see 12:47 and then 1:38 and then 2:19 and 3:18. And it feels like the only time that I'm not watching the clock in a circle is if I take Ambien. So those three, because you mentioned the Lunesta and you mentioned melatonin, you mentioned Ambien, where is that putting us in that sleep cycle?
I mean, it does allow you, it prevents you, you've got this threshold, it's called a sleep threshold, and you're not as likely to wake up if you take a sleep aid, no question. And you're capable of staying in that REM stage longer so that you then remember your dreams. Everybody dreams. A lot of people say they don't dream. They dream. They just don't remember their dreams because they don't stay in there long enough. So any sleep aid, including melatonin, allows you to stay in whatever stage of sleep you're in at the time without getting woken up or aroused out of it. It's also called the arousal threshold. The problem is any sleep aid besides melatonin can impact the respiratory breathing muscles as well. So that's why when you're doing a sleep study, it's a little bit false if you have to take, because you have something foreign either on your arm, in your nose, whatever you've got on. It's a little foreign. So sometimes somebody will take a sleep aid to help them get to sleep with something weird on them. The problem is it gives a false representation of their average sleep. So we try to get people not to take any meds before they go to sleep because it really can make apnea a little bit worse. So that's right. Unfortunately, that's what a lot of primary care doctors do who don't know anything about sleep. They really don't. They don't know enough about sleep to know that if this patient has insomnia, they prescribe them sleep meds, sleep aids like Ambien or Trazodone or any of the plethora of meds that are out there now without ever giving them a sleep study. And if it sedates the respiratory muscles, which they do, it can make apnea worse. And it's just not what you want to do.
How do those work? I hate to be the guy, the doctor that says I take a pill, I don't really know how it works, right? But so I know there's CNS. How do those three drugs work?
Well, melatonin primarily, the reason why it's so accepted, 6-7 years ago, we thought melatonin used up the receptors. We all have melatonin receptors. And our brain is supposed to, the hypothalamus gets triggered to release melatonin and it attaches to the receptors. And that's when we go to sleep, right? So we need to have melatonin in order to affect that. If we don't have enough melatonin producing, then exogenously we take it, it takes the place of the melatonin, fills up the receptors and lets us go to sleep. Nothing bad can happen from that over long term. That's why they've approved it long term. Used to, we thought that our brains would stop making melatonin if we took too much melatonin because it would say, well, hey, you're taking these pills, you don't need to produce anymore. But that's been debunked. That is no longer thought. So you can either take melatonin or something called Ramelteon. Ramelteon is a prescription medicine that is merely an agonist for melatonin. It helps you create and produce and secrete your own melatonin and open up the receptors for it. So that's Ramelteon, melatonin. All of them, yes, they depress the central nervous system. That's what they're doing. They're putting you into parasympathetics. So it's unfortunately, where you need to be really careful is taking anticholinergics. And a lot of people are doing this. They're taking Tylenol PM, they're taking Benadryl, and they're doing it every night. Anticholinergics will prevent your body from creating choline. You need choline periodically. If you suppress it for too long, they've shown that will also lead to early Alzheimer's. So taking anticholinergics, just look on the bottle. If it says it's an anticholinergic, periodic use is fine, long-term use, not fine.
And Benadryl is one of those as an antihistamine?
Yes, it is.
Interesting, because I do take Benadryl in the morning, every morning.
Every morning?
Yeah, I have allergies and it doesn't make me tired. I just think it's fighting all histamine responses that I would encounter.
Most people take it at night to help them go to sleep.
I take it first thing in the
morning.
morning. I take 2 pills in the morning.
Good grief. You know, there are short sleepers. Now, short sleepers, you have and that's probably what you are. You're technically, you're a short sleeper. You have a defective clock gene.
Well, thanks.
There's a clock gene.
People have said worse things about me. Believe me.
There's a clock gene in every organ of your body, including your lungs. I mean, every organ's got clock genes, but they can be defective, or it can actually, it's a benefit for people. And that's why we find the most successful people seem to be these short sleepers. They're the CEOs of huge organizations. They're presidents. They're all these people because they require less sleep. They can be more productive. They feel more energetic. And that's you, David.
That's me, I guess. The other thing too, and I appreciate you talking about that. Maybe I'm the only one that was interested. Someone had said, covering their eyes at night, wearing, some sort of, eye covering helps them sleep. And you know what I found, and I'd like your input on this. So I live in a high rise downtown San Diego, and I don't pull my curtains down at night. It's like Vegas. I mean, there's so much, not noise necessarily, although we get noise. It's just light, right? And, I think that certainly helps with me not sleeping well as either, because I know if I go on vacation where there are like dark blackout blinds,
right?
Sometimes I wake up in the morning if the blinds are dark and I have no idea what time it is. So how does that fall into your whole recommendation of people that, take me, for example, I come in and say, I'm never tired, but I'm a little worried that I never sleep, right? And I got to take Ambien 2 or 3 times a week just to get my mind to stop thinking. How do you put environment into your diagnosis and treatment?
Well, you saw me talk about the sleep gate. As long as you're asleep somewhere between that 11 to 5 time frame, that's important. If you sleep from 3 to 7 or 3 to 8, that's not good. But you seem to be staying within that time frame, which is good. So really, honestly, the people that we don't counsel for these sleep problems, or at least sleep hygiene, let's call it, are those that don't have a problem getting to sleep or staying asleep. If they don't complain about that, if they don't have insomnia, either sleep onset insomnia or sleep maintenance insomnia, then I don't counsel them on light and noise and caffeine and all the kind of things that I counsel people over. But if they say, listen, I sleep terrible, I cannot, I wake up 8 times a night and I feel terrible. And even if I sleep 10 hours, I'm still sleepy. And all right, then we talk about sleep hygiene. It's cognitive behavioral therapy for insomnia. CBTI is the technical term for that. And we usually send people to a psychologist that specializes in CBTI if they're that bad off. Otherwise, I can talk to them easily about, limiting caffeine. I wear a blackout mask every night. I have done that for years. I've got one in my travel suitcase. I've got one in the drawer next to my bed. I think I even have one in the office. So I never want to be asleep without my sleep mask.
Right.
Because I used to thought, I sleep pretty good. I sleep, but then I put on a mask, much better. I had no idea how good you could sleep until I blacked out my environment. So that's good.
And I'm the kind of person, like you described earlier, I couldn't do a sleep study with something on my finger, and I tried to do a home one with a pulse oximeter. It was across the room. Yeah. I could never have a CPAP because I would be wrapped up at like I was wrestling with a boa constrictor all night long. Even putting on, sometimes when I fly internationally, right? And, I'll wear it. It's like, I can't sleep until someone takes this off my face, right? But I wonder how you're counseling people on environment.
Yeah. Well, I counsel them on environment if they don't sleep well. The 22-year-old that comes in and they just snore because their bed partner said, dude, you got to get this taken care of. Right. I don't counsel them on sleep hygiene because they go, listen, doc, I sleep fine. It's her problem. I sleep great. Yeah, that's not a sleep hygiene thing. I don't counsel that guy at all. We just fix the snoring.
Yeah. Okay, good. Thanks for taking the time to address
it. Oh, you bet. Yep. How many people in your office snore? Okay, we think, you know, their stats are all over the place. Basically, I know there was somebody here from Canada that's listening in. I know that if you're in Canada, you're more likely to snore. That's about all I can get from all of these different studies that have been done. So you probably snore, whoever you are from Canada or Toronto, was it? I can't remember where you said they were from. So basically, a lot of your patients snore. And if you don't ask them about it, they're not going to tell you. There's no reason for them to tell you, hey, dentist, by the way, I snore. Yeah, there's no reason for them to tell you. So you got to ask. And I promise you, you will be shocked at how many do that. And then all you got to say is, if they check the box, say, yep, I snore. Hey, have you ever had a sleep study? Have you ever had the health of your sleep checked out? It's not a hard question. It's not going to ruin your day. It's not going to divert you from talking about crown and bridge and veneers and all the stuff that you want to talk about, your bread and butter. I get that. Sleep is so important. So at least broach the subject with your patients, because so many of your patients have sleep problems. I can promise you. So this is sleep apnea. It's when the tongue drops back. For those of you that have it or snore, you know that you snore worse when you're on your back because it's a gravity disease. Everything collapses. Your soft palate, your tongue, your uvula, all this flops back, shuts off the airway. That's why with our appliances, you know, we hold the mandible forward to keep this collapse from happening. The CPAP machine blows air through the nose, and you turn the pressure up as high as you can get it in order for it to bypass the tongue and to blow past. So the airway obviously is restricted. This obstructive kind is by far the most common, and almost all of it's right back there in the back of the mouth. So when you're looking in the oral cavity, and I know you dentists look in the oral cavity, you're looking in there, look at the back of the throat, see how clogged it looks. You should be able to see the back of your throat, their throat. In fact, go home, look in the mirror when you get a chance. Don't leave this right now, but when you get a chance later, look in a mirror and open your mouth and see if you can see the back of your throat. If you can't, you have an obstruction. Your tongue is raised up too high. Your pharyngeal walls are too closed in. Your soft palate drops down. Something's going on there. It's very easy for us to look in the back of the throats of our patients. And if we can't see the back of the throat, hey, how you sleeping? Again, easy question. I mentioned what central sleep apnea is. The patient just doesn't even try to breathe. It's when there are serious health conditions, typically, but it's about 1% of all those that have apnea have central. Now, bad things happen when you have sleep apnea. I mentioned cardiovascular disease. The heart is the first organ that's impacted. You're more likely to have a stroke. You're more likely to have diabetes, to have metabolic syndrome. If you go into the hospital, you're going to have to stay longer if you have sleep apnea. They're going to put a CPAP on you because they realize when you're sedated, you stopped breathing, and they're going to have to put a CPAP on you. And they're going to say, dude, when you get out of the hospital, you got to go get this tested because you stopped breathing during surgery. Impotence, menstrual irregularities, enuresis. This is frequent bedwetting. We see this obviously in kids. It's very common in kids with obstructed breathing. If you've got a child or a grandchild that wets the bed when they're 3, 4, 5, 6, 7, 8 years old, they probably have large tonsils and adenoids. We don't have time to go into all of that. But as adults, you have nocturia. Nocturia is when you go to, you get up to use the restroom more than once. One time in the night to use the restroom is okay. 2 times means you have nocturia. And in men, the most common reason is sleep apnea. You could have an enlarged prostate. With women, it's either hormones or obstructive sleep apnea. But if you get up more than once to use the restroom, something's not right, and you need to get that looked at. Untreated sleep apnea lowers the bar for depression, lowers that threshold, so it's much easier to get depressed. That's why a lot of patients that I have coming in to get treated for sleep problems in my office, they have ticked off that they're taking an antidepressant. It's very common. The problem with taking antidepressants is it will negatively impact REM sleep. That's not something a physician ever tells you. They don't say, listen, I'm going to give you this antidepressant, but by the way, it's going to decrease your REM sleep. And REM sleep is very important for survival. In fact, they've tested horses and a few other animals. They can live about 2 weeks before they will die without REM sleep. And we're taking medications that depress the ability to create REM sleep. Not good. Now, I'm not ever telling a patient to stop taking their antidepressant, but they deserve to know what's happening as a result of taking that. Acid reflux. Many people don't realize that the reason they're having to take these medications for acid reflux is because they have untreated sleep apnea. Very common side effect. You mentioned bruxism, David. They're going to destroy dentistry if they've got an airway problem. I know you can put them in bruxism guards, but I mean, is that treating the problem? That's a Band-Aid thing. So yeah, and it doesn't mean that if we treat their sleep breathing disorder, they won't brux. There are other reasons besides sleep disordered breathing, but it certainly is one of the side effects. You're more likely to gain weight if you have sleep apnea. Increase in C-reactive proteins. My brother is a neurologist, ophthalmologist. He's done surgery on the optic nerve. And he can tell by looking at the optic nerve when he does a surgery when there's a lack of oxygen perfusion to the nerve. He says, I can predict that somebody has sleep apnea by looking at their optic nerve. There's actually 3 different eye diseases. Every once in a while, about every 6 months, I'll get like 3 referrals from an ophthalmologist or an optometrist in one day. And I'll know it's because they read an article or they were at a meeting or something where they learned that there's a connection between sleep apnea and these eye diseases. But then they forget about it and they stop paying attention to it. It's just like we do in dentistry. So what, as a dentist, what can you look for? Large necks, obviously. Large neck with a man, 17 inches or larger. Most men think they know what size their neck is, but you need to subtract about an inch from what you think your neck size is, because we buy dress shirts that won't choke us. So we buy them a little bit bigger. Women won't have a clue what size their neck is. They've never measured it for any reason. About 15.5 inches for women. We look at retrognathia. If you've got this either a small mandible or retruded mandible, you're more likely to have sleep apnea. If you have a deep bite, yes, you can restore that, of course. And I encourage you to restore that to increase the vertical dimension on patients, which you almost always do when you do a full mouth restoration, right? Yeah, you've got worn down dentition, increase the vertical dimension. They have more room for the tongue. A deep bite is another sign or symptom or precursor for sleep apnea. So pay attention to that. Obviously, we can see weight problems in the chair. We know those patients that are overweight. Scalloped tongues means you have a 3-car tongue in a 2-car garage. You don't have enough room for that tongue, so it takes on the shape of the internal of the lingual aspects of the premolars and molars. It's just a squished tongue. So when they go to sleep, it falls back in the back of the airway, shutting it off. Pharyngeal constriction, those are these walls you see in the back of your throat. Again, you probably couldn't draw a picture of what the back of your throat looks like because you just don't pay attention to it. When you look in the mirror, you'll see these pharyngeal walls that are coming in like this. If they're all the way in and almost touching, that's bad. That's an anatomical problem, and that can shut off the airway as well. Eroded enamel is a sign, can be a sign of acid reflux, obviously, and bruxism, which we've already discussed. Enlarged tonsils. We see some adults with large tonsils, and depending on what their sleep problem is or isn't, we can have them. It's not as much fun to get your tonsils taken out as an adult, but sometimes it's the best thing for airway. If they have a vaulted palate, they're more likely to have sleep apnea. Tongue bars and studs in the tongue, it forces the tongue back when they close their mouth when they're asleep, so that can be worse. Maxillary splints can impede the airway. We know through some research that mandibular splints do not cause a problem, but maxillary splints do. So I was taught going through Baylor College of Dentistry to do maxillary splints. And every time I do a seminar, I ask them what's being taught now, and I find some fairly recent graduates, they're still being taught maxillary splints. So get away from maxillary, do mandibular, do NTI, do something. I don't care what you do, just stay away from the full Michigan type maxillary splints. And then full dentures can impact the airway when worn. So it really depends on the vertical dimension of the denture. So I would say if you've got a patient who's worn those dentures down, that can be a problem for them to take them out. They're actually going to breathe better. Well, anyway, find out if your patient has dentures, how well they sleep. And at the Medicare age of 65, 50% of those people have obstructive sleep apnea anyway. So you're 1 out of every 2 patients in your practice that are 65 or older, you need to get in for a sleep study. Drowsy driving is one of the main reasons that I'm so passionate about this. You wouldn't believe how many people fall asleep at the wheel and kill themselves and other innocent people every single day. All kinds of injuries. Most of them occur between midnight and 8 o'clock in the morning. And as I said, between 1 and 3 in the afternoon. It's like you're driving drunk. Now, we don't let people drive drunk. And in fact, I can promise you, I mean, that's why Tesla is so popular. People falling asleep. That we're going to have cars in the next 10 years that have sensors on the steering wheels that can reflect off your eyelids. And if it knows that your eyelids are closing, it's going to shut down the car. So just don't get sleepy when you drive. There's lots of bad things that can happen. But you need to counsel your patients about this as well. You know, sleepiness is not good, especially when you're driving. This is my Lexus. It had 800 miles on it. I was flying off to Kansas or something to do a lecture. This has now been about 8 years ago. Flying off, when I landed, my daughter borrowed the car to go to a party with her 6-month-old daughter, which was my granddaughter, and she was seated right there. They were parked on, you guys that don't know Dallas highways, it's I-35, it's an interstate. It was standstill traffic. They were parked and somebody hit her from behind 65 miles an hour. And all we know about that driver is that she was doing one of 2 things. She was either texting or she fell asleep at the wheel, because this was around 2:30 in the afternoon during one of the sleep gates. My daughter and granddaughter walked away just fine. They're fine because Lexus has this amazing ability to prevent death. I'm a huge Lexus fan. In fact, I just got my 8th one, I think. I keep leasing every time the lease comes up. I can't see me ever going away from them because of this crash field that they got a bar out there that won't allow people to be harmed. And thank goodness that's what happened. All right, so let's look at something that I think is really one of the most fascinating studies I'm aware of as relationship to the heart and sleep apnea. The likelihood of you having a heart attack. Let's say 1.0 is the standard. If you're overweight, you're 7 times as likely to have a heart attack. If you have high blood pressure, you're almost 8 times as likely. If you smoke, you're 11 times as likely. If you have obstructive sleep apnea, even a mild case of it, 23 times as likely to have a heart attack. So if you want your patients, your family, your friends not to have heart attacks, get them in a sleep study. See if they've got any sleep problems. It would be worth it. Save their heart. So how do we diagnose these problems? I mentioned the polysomnogram as well as the HSTs. You either go into a sleep lab, you do it at home. Not many people are having polysomnograms in a sleep lab these days because most insurance companies will not allow that. They have to pay too much for a PSG or a polysomnogram. That's where somebody watches you all night sleep. So you have to pay somebody to do that. That's why insurance companies they only want home sleep testing done these days. And in most states, us dentists can hand out sleep studies, not all states. New Jersey has a problem with it. Georgia has a problem. I think Colorado tries to restrict it. There's a few states that they've said dentists can't do this, so you have to create workarounds. It's possible, but these sleep studies, we own about 25 of these monitors. We're handing them out all day long. Thankfully, in Texas, we can do that. This is the difference between an in-lab study and a take-home study. Now, which would you rather do? Would you rather sleep in somebody else's bed with their temperature and their noise and their lights, their pillow, with all these things hooked up to you? Or would you rather be in your own bed with something hooked up to your wrist like this? I mean, what's a truer look at your sleep? Yeah, I think you know that. And that's why this is now what we consider the gold standard, the home sleep test. Again, the WatchPat's my favorite. There are 4 or 5 other really good ones. It's not like it may not even be the best according to a lot of other people. I just like it the best. Again, this is what the study looks like. Dave, we got more questions coming in that I need to answer.
One was, at what age do you start the screening and treat sleep disordered breathing?
Age 4.
And typically, what would be the symptoms that a parent would come in and you'd say, we need to.
Yeah, it's going to be ADHD tendencies. That kid, they have him on meds because he's got ADHD. He's wetting the bed. You get him in the morning, and the covers are everywhere. It's always his head's at the other end of the bed. They're never neatly in place when he wakes up. Those are the main things. I mean, you might hear snoring, but most parents don't want to go in. You know, they get their kid to bed and they creep out, and the last thing they want to do is that kid to wake up. But it would really be helpful if your kid usually wakes up at 7:30 or whatever, go in there around 6:30, 7 o'clock, whatever, sneak in there and just watch them for about 15 minutes and see if they stop breathing at all. Or have what we call paradoxical breathing, which is common in infants. It's when you breathe with your stomach out and your chest in. Stomach out, chest in on an inhale. That's paradoxical breathing. If kids do that, they have a sleep disordered breathing. Those of you with infants, don't worry, that's normal. They grow out of that, or they should grow out of it. If they don't, that's a breathing problem. So those are the main things I would suggest for patients or parents of kids or grandparents of kids. Really evaluate the ADHD that has been, quote, diagnosed. If the doctor diagnosed ADHD and knows about sleep problems and sleep apnea, by far the most common reason at that age is tonsils and adenoids. So you've got to look in the back of the throat. Problem is ENTs don't make a lot of money taking out tonsils and adenoids. They just don't. But it's the right thing to do if that child is not growing properly. It will stunt their growth if they're not breathing well. If your child is under average in growth and his or her classmates are outgrowing him, could be a sleep problem. Something to look at.
Are they teaching much sleep dentistry or growth dentistry and orthodontic and pedodontic programs, do you know?
I think they're getting better at it. The pediatricians, they're hard to get through. The pediatricians pretty much say they'll grow out of it. Yeah. They'll grow out of it. And what they're used to seeing is, yes, on average, as the head gets bigger, the head outpaces the tonsil growth, so they can breathe better. The problem is they're not going to grow as well. And at age 4 is when they're most likely to have a breathing problem. It's when the tonsils are big enough and the head small enough to create that airway problem. Okay. And it's the only time when females are more likely to have apnea than males. 9% of females at age 4 have sleep apnea. 9%. 6.7% of boys do. So in other words, it's not rare. Yeah, it's a smaller percentage, but it's something that should be looked at, especially if it's your own kid.
Yeah, and I had my son who's 22 now. When he was a kid, I mean, literally, it was like the hands of a clock. He'd be sleeping like this, then like this, halfway through the night, his head was facing the foot of the bed, and, he was just rolling around like this. So let's go back to what you said, 9%. And, we're all who had kids or have young kids are thinking, uh-oh, what do we do? Or we have patients, right? So treatment at that point typically would be a referral to an ENT that's kind of clued in.
Yep. You've got to find an ENT that cares enough about kids and their airway and knows about airway, because all you have to have, there's like 12 things that an ENT can use to create medical necessity for removing tonsils and adenoids. One of those is witnessed apneas by the parent. So that's why it's important for you to go into the room, and if you see your child stop breathing one time, that's all you need, because apnea in a kid is graded a whole lot differently. With an adult, you have to stop breathing 5 times an hour to have mild sleep apnea. With a kid, it's 1 time an hour. Okay. So whole different look at it.
So when we hear these, again, I'm going to go back to my own child who ground, he would have woke the neighbors grinding his teeth. So a lot of the grinding and the wear of the enamel of these primary teeth, sleep related or apnea related?
Yeah. There's a study out of Brazil that they did where they had 66 kids who had obstructive sleep apnea. They had been diagnosed with it, and they had large tonsils and adenoids. They had tonsils and adenoids removed. 100% of the apnea went away, but also 44% of those kids were bruxing. That dropped to 11% when they took the tonsils and adenoids out. So there's no question that sleep disordered breathing, even in kids, not only in adults, but in kids, bruxing, and I'm sorry, I should have brought that up when you asked what should you look for in kids. Yeah, if the primary dentition is worn down and you're worried about those first molars when they come in, that they're going to wear those down, all that grinding has happened in their 3, 4, and 5-year-old age group when their tonsils and adenoids are the largest. So that's the time to worry. And if your child has ADHD tendencies, is wetting the bed, all the covers are messed up, is smaller than his other classmates. Yeah.
Okay, since we're on this subject, I hate to interrupt your train of thought, but this is a tangent I think a lot of people are interested in. So 2 things. One is, what would you recommend? I'm going to do this 2-part and have you answer it separately. What would you recommend? So all of a sudden, whoever's listening, and me included, think, wow, this is a big deal. I need to find an ENT that's clued in. So what would you recommend, the questions that should be asked, or what associations or organizations they're members of ENT? So I'm not just sending and the guy says, yeah, give them Benadryl or Sudafed, right? And the second is the whole orthodontic issue, right? And someone asked about myofunctional orthodontics for improving the airway. And let's talk about now I know you guys do ortho in your practice,
right?
But what kind of conversation or what things should the average restorative dentist who's not doing this ortho, the kind of questions they should be asking orthodontists? Hey, can you help my practice out here or my patients?
Yeah, unfortunately, now I fully believe that when you start taking out teeth, premolars, four premolars, you're going to increase their chances of having sleep apnea. Unfortunately, there is absolutely no research to show that happens. So, and the reason is it would create all kinds of lawsuits, and so orthodontists are unwilling to do any research in that area. They don't want to be part of that. But yeah, it's you need an orthodontist that understands airway and say, listen, how often do you recommend 4 premolar extractions in ortho? That's a good question to ask somebody. Orthodontists have come to my sleep seminars in the past, but there aren't that many that know about airway. Some are very well versed in it, and they've taken some education in it, and they know about airway, and they know not to take out teeth. I would just say, if you're going to be referring your kids to an orthodontist, make sure this is an orthodontist that's up on the literature with kids and breathing. Make sure they're aware of that, and only take out teeth that absolutely have to be removed. Yeah. So that's the orthodontics. ENTs, there are some ENTs that have actually gone on to get a sleep specialty. They are board certified in sleep medicine. So if you've got an ENT in your area that is board certified in sleep, luckily in the Dallas area, we have a couple. They're great to work with, and they pay attention. So that's the kind of thing I would look for.
Now, are you doing in your ortho? Are you doing myofunctional ortho as part of that?
I'm not. There definitely is a place for that, because we know there's actually research now to show that myofunctional therapy can improve the airway. No question. So I am a fan of it. It's just not something that we have done in our office. I'm frankly just too busy treating adult patients all day long. So yeah, it's important and it should be done. We just don't do it.
Okay, and I don't want to hold you up because we haven't really got into appliances yet. But are you using appliances, sleep appliances in children instead of the adenoids, tonsils?
No, I'm suggesting they get adenoids and tonsils removed. Now, have we done? Yes, sometimes kids get adenoids and tonsils removed and they still have apnea. And so, yes, I'm doing it, but it is a labor of love to make an appliance for those kids, because as you know, the dentition keeps changing and you've got to keep changing it out all the time. So you're going to lose money treating that kid, but it's important. So yeah, we do it.
Okay. Anyway, I apologize. You did awesome. I appreciate that.
Okay. So a CPAP, as I said before, it uses pneumatic pressure to force air past that. You just turn the crank up. So when I talk to patients about the different therapies, basically there are 3 different ways to treat the airway. There's a CPAP, there's an oral appliance, and there's surgery. That's it. There's 3 ways to do it. A CPAP, so look at it as you're watering your garden. You're in there washing the dishes and you look out the window and you realize, oh no, my garden hose is kinked. My garden isn't getting any more water. What do? With a CPAP, you go over there, you go to the faucet and you just turn it up and try to get the pressure high enough so it will unkink the garden hose. If you're going to do surgery, you go, well, gosh, okay, why don't we just cut the hose right before the kink and then hope the water gets all the way to the garden. With our appliances, we're going out and unkinking the hose and letting the water or the air flow on its own. That's the way I explain it to patients in the 3 different therapies, because this is a false way of opening the airway. It's forcing air, room air, into the lungs when you're asleep. I mean, that's the way you open the airway. And yes, it goes through a filter and a sterilizer, and not a sterilizer. It filters the water. It distilled water is supposed to be used so that it's as clean as it can get, and it's humidified. But still, saw a patient today. The reason he came to see me is he gets sinus infections when he wears a CPAP machine. They'll tell me they get bloated because more air comes in than they can exhale. So that's a very common thing. If you talk to a sleep physician and you say, you ever have a patient tell you they get bloated from CPAP? They'll say, no, we get it all the time. So they're not being honest with you. Anyway, I won't belabor that. There's lots of problems with CPAP, which is why it's only 50% of people that can wear one. 50%. The other 50%, they need your help. These are oral appliances. They're getting better and better and better. Now computers are making them. Digitally, of course, we scan. I know not everybody has scanners and uses scanners. We use them exclusively. My team doesn't even know how to take impressions now because they haven't done it in so long. So everything's digital now. We scan the teeth. We digitally send the scan to the appliance company. They then use a computer to make the appliance. They design it on a computer. It's made by a computer. So when it's done that way, the fit is very accurate. It's strong and it's small. You can make them small and strong if you employ those techniques. So this is a company called ProSomnus. It's my favorite company to work with. There are plenty other companies. Somnomed, Panthera, Great Lakes, Oasis, TAP. There's lots of companies that make these appliances. the EMA. I kind of like this company, and they get most of my, AMAC is another company. It's a fairly new company out there. They've got a nice, inexpensive appliance for those that want to get in inexpensively. But this, the Prosomnus is my favorite. This is a new material. This is called an Evo, and you can actually bend this. I wish I had one here, I could show you, but it's a flexible material now that's just, we've been using it now for about a year. I've made about 350 of these and have not had one break in the last year. Not, of all the ones I've done, not one is broken. And I have to knock on wood every time I say that, because I know at some point one of these is going to break, but that amazingly resilient. Oh gosh, I already got to the end here. I kind of rushed through it, but
Oh, you did good. You did great.
yeah,
that was awesome.
Okay.
No, you're perfect.
Okay, good.
So a couple of questions did come up. And I appreciate, Kent, you're amazing, and I really appreciate that.
Thank you.
So what about the Inspire?
Yeah, Inspire is something that is catching on in some of the larger metroplexes. A lot of the beta testing was done here in the US, I mean, in Dallas. It's basically a pacemaker for the tongue. And since your pacemaker may be on your left side someday, they implant it on the right side because you don't want to take up valuable real estate over here. So it's implanted right here, and then a wire is run up to the base of the tongue, and then you have a remote control, and you turn it on when you go to sleep. And when you start to inhale, it sends a subclinical impulse to the base of the tongue, and the tongue pushes forward as a result. It costs about $40,000 to do that. Medicare started covering it first, and you have to go through a whole bunch of stuff in order to get approved for it. You're supposed to fail both CPAP and oral appliances to get Inspire, but it's an effective therapy that can be useful for some patients.
Okay, good. How about the MyoBrace Vivos?
Yeah, that's a lot to get into. Vivos is becoming more and more popular. I'm seeing a lot of dentists in my area, they're doing it. I don't currently do it. Again, because I've got more than enough to do with the therapy that I'm doing, but Vivos does have courses out there that they offer. I can't really speak to the efficacy or the cost or anything like that, just because I don't do it. So I feel out of place trying to address it more than that.
Okay. And what was the name of the appliance that you started using? And someone asked the approximate cost, lab cost for that.
Yeah, not cheap.
Yeah.
Yeah, it's the Prosomnus Evo, EVO, which stands for evolution, you know, Evo. It's really the newest one out there that I know of. I don't think there's anything newer than that. And the cost is right at $600.
Okay. Which is kind of equivalent to 350 to some, yeah, about the same.
Yeah.
Okay. How about the airlift surgical technique?
Yeah, I mean, anything there are like 80 surgeries out there. And you can go in the back half of the tongue and use a robot to remove the back half. You can go in and the hyoid bone, lift it up, the lifting procedure. Again, these are done by ENTs. There's pillar implants you can put in the roof of the mouth. You can get maxillary mandibular expansion, MMA they call that, where you bisect both mandible and maxilla and move them both forward in the face. Steve Anderson had that procedure done, cleared up his airway. It is a very effective surgery. It's just an expensive thing to do, and you got to go through a lot to get that done.
Yeah. So if you give an appliance, so let's say I came in and you found out I wasn't breathing X amount of times at night, and you made an appliance, do you follow through with then a sleep study with the appliance in place?
Oh yeah, we insist on it.
And then how often do you repeat that? So you say, oh, look at David, you're doing great. And I say, yeah, I love it. I can't sleep without it. Do you follow up a year from then and say, let's do it again, or not so much?
Well, yeah, because people change. People gain weight, people get older. So we do follow them up. We usually see them a month after we deliver, then 3 months, 6 months, and then every year after that. That's our follow-up program. We have a really great recall program, just like you have for hygiene. We have a recall for sleep. It's kind of an evergreen profession, because about every day we have somebody coming back in that we made an appliance on 3, 5, 8 years ago, that now they need another one because they either lost it, their dog ate it, it's worn out, They just want the newest appliance out there, whatever.
Okay. So let's talk a little bit about dentures, because so a patient comes in and has an existing denture, and you mentioned the Shimbashi number. Maybe some people don't know what that is, but it's basically the measurement of CEJ to CEJ of like tooth number 8 to tooth number 26, right? And we do that in restorative. And it was kind of interesting is, you open someone's vertical, and we're taking these people that go to a sleep study. They have a sleep problem, right? But they need restored. So we restore them, we open their vertical, and they go and get their sleep study again, and everything is fine.
Yeah.
And we also use NTI. I don't use a maxillary split. I'm not a firm believer in a full coverage balanced splint. I think people tend to clench a little bit more. And it forces, if they're a clencher, it forces their mandible into a position. I mean, when we use an NTI or any type of anterior midpoint appliance, we're finding these people, because it allows their brain can move their jaw forward onto that discluding element, all of a sudden they stop snoring. We've had sleep studies with NTIs. I mean, that's $100 appliance. And, their apnea problems go away, or the breathing order.
Yeah, and sometimes it's just increasing the vertical, because that also increases the vertical.
Yeah, and it gives the mandible an opportunity to move forward.
Right.
So let's go talk about dentures. You have a patient comes in and they've got a denture, and it seems like the AP position is right. It seems like the vertical is right, or it could be a implant supported, like an all-on-4, all-on-6, or whatever. Do you make sleep appliances on those? What would you do with a denture?
Yeah, we do. Yep. Now the mandible has to be supported enough. The mandibular denture is the most likely one to come loose. So if it's implant supported, yeah. Or if they're willing to wear adhesive on that lower denture, but the maxillary denture that's no problem. But I do tell, what we'll have to do is we'll use a number 6 round burr, and we'll go into the papilla areas between the molars and the premolars and create little indentations, so the appliance locks in to that. Patients never care. They never see those little divots in the papilla area.
You're talking about on their denture.
On their denture.
Yeah, I was going to say, that sounds painful.
Yeah, the only problem with dentures sometimes, because of the retrusive forces, like their mandible's pulling back and putting pressure on their maxilla right here. So they'll sometimes develop sore spots in their canine areas. And we tell patients that. But normally these are Medicare age patients, and our Medicare patients get treated for free because Medicare pays for all of it. And we tell them, you know what, there's about a 50% chance that we can make this without discomfort, but it's not going to cost you anything. So why don't we give it a shot? And half the time it works well.
Good. Well, I know, I think you'd be the first person that would say that an hour and 45 minutes doesn't make us sleep experts. I think it educates us, and it's so important because we're not getting educated, and you did an amazing job. I would highly recommend, and you can't say this as well as I could, because I can toot your horn louder than you can toot your own. What Ken is doing as an educator with his hands-on seminars, they're a weekend, and he does multiple types of seminars. I sent my ex-associate there. She came back, of course, with all this knowledge, his sleep appliance and a at-home sleep study machine. I don't think that anyone does it better than you, honestly, Kent. And, you see on the screen in front of you, 21st Century Sleep Seminars. You could go there, you could register, or you could email Kent with individual questions. We didn't get to a couple questions. Some of them were kind of repeat, and we kind of ran out of time, and I apologize. Someone asked about restorative position. I told them to email me separately. You may have seen that. CR.